My name is Jeremy Carter, and I will be presenting DDimer as a rule out for acute aortic dissection. I am core faculty and an assistant professor of emergency medicine at the University of Texas Medical Branch in Galveston. Acute aortic dissection was first described in the autopsy of King George II in 1761. This, of course, is a tearing away of the tunica intima with or without the tunica media in the blood vessel, creating a false lumen. This has a very high mortality. Untreated acute aortic dissection has an estimated mortality of 1 to 2% per hour. Overall mortality is 22% for type A aortic dissections and 13% for type B aortic dissections. Prompt diagnosis decreases mortality, but this can be difficult due to a variety of presentations which can imitate more common disease processes such as acute coronary syndrome, pulmonary embolism, or renal colic. The most common presentation is acute onset chest pain or back pain. This occurs in about 85% of acute aortic dissection. There is a phenomenon of painless aortic dissection, which occurs in about 6% of patients. This presents with syncope, a new neurologic deficit, or new onset congestive heart failure. The classic physical exam findings of hypertension, a diastolic murmur, or widened pulse pressure are frequently absent. This can contribute to delays in diagnosis and therefore increased mortality. And the classically quoted finding of greater than 20 millimeter mercury asymmetry in upper extremity blood pressure, which can be present in type A aortic dissection, is frequently present in patients without an aortic dissection and also can be absent in patients with a type A dissection. Helical CT and CT angiography are 100% sensitive for aortic dissection, and these are the most commonly used imaging modalities for establishing the diagnosis. Transesophageal echocardiography is a viable option and is widely used for unstable patients, but of note, TEE is highly user dependent and high rates of false positives and false negatives have been reported with inexperienced users. The increasing use of CT is a well-documented issue in the emergency department. Overuse of CT leads to unnecessary cost and increased length of stay. In order to reduce the number of unnecessary CTs, a biomarker has been investigated, and the ideal biomarker would have a high sensitivity for aortic dissection and therefore would be able to facilitate ruling out the disease. This biomarker, of course, is the DDimer. The diagnostic value of the DDimer was first explored by Weber and colleagues in 2003. 10 patients with acute aortic dissection were found to have elevated D-dimers. This, however, has been difficult to study as the rarity of the diagnosis of acute aortic dissection has contributed to a relatively small number of patients being enrolled in aortic dissection trials. For example, one of the most reported trials was done by Nazarian. This showed a high sensitivity of a D-dimer with a cutoff of 500 nanograms per milliliter. That sensitivity is 0.98. However, it only enrolled 1,035 patients with suspected dissection, and of that group of 1,035, only 233 had a final diagnosis of acute aortic dissection. There has been a large systemic review and meta-analysis done by ASHA. This had a total number of 1,557 patients. Of those, 473 had a final diagnosis of aortic dissection, and they reported a similar sensitivity of 0.98. Most of the patients in the ASHA trial were, however, from the Nazarian trial. Of the 1,557 patients in the meta-analysis, 1,035 were from the Nazarian trial, and of the 473 who had a positive study showing aortic dissection, 233 were from the Nazarian trial. So the purpose of our study was to explore the sensitivity of DDimer for aortic dissection in a larger cohort of patients than had been previously studied. This was a retrospective cohort study using the Trinetics database. The database, which included 57 healthcare organizations in the US, was sampled from October of 2002 to October of 2022, and a total of 1,318 patients with the diagnosis of aortic dissection who received a DDimer at the time of diagnosis were identified. These patients were then subdivided into groups from 250 nanograms per milliliter levels of DDimer to 2,600 nanograms per milliliter levels for DDimer, and they were subdivided into 50 nanogram per milliliter segments. We found that total of 1,318 patients, and of those, 1,252 patients had a DDimer above 400, and 1,227 had a DDimer above 500. This gave the 400 nanogram per milliliter cutoff a sensitivity of 0.949, and the 500 nanogram per milliliter cutoff a sensitivity of 0.93. These were the demographics of the patients sampled. A little over half were male. They were predominantly white, and we had a mean age of 66. As discussed on the previous slide, 1,318 patients with the final diagnosis of aortic dissection who had a DDimer drawn at the time of diagnosis were identified. Of that group, 1,252 had a DDimer above the 400 nanogram per milliliter cutoff, and 1,227 had a DDimer above the 500 nanogram per milliliter cutoff, giving the 500 nanogram per milliliter cutoff a sensitivity of 0.93, and the 400 nanogram per milliliter group a sensitivity of 0.949. Previous studies had really established the cutoff of DDimer to be 500 nanograms per milliliter, which in multiple other studies have shown a pooled sensitivity of about 0.97 to 0.98, with a negative predictive value of 0.96, making it a potentially useful tool to rule out aortic dissection. Our study found a lower sensitivity for DDimer at 0.93 for a DDimer above 500 nanograms per milliliter. This is likely secondary to the difficulty in differentiating chronic aortic dissection from acute aortic dissection in the Trinetics database, and multiple cases of chronic aortic dissection were likely included in our numbers. Chronic aortic dissection would not likely raise the DDimer, and this therefore could skew the sensitivity. The primary strength of this study is that it's the largest individual study for evaluating DDimer that we have been able to find. The largest previous study was The single study only included 1,035 patients, of which 233 had a known dissection. Ours had 1,318 patients with aortic dissections. This made it about 5.6 times larger than the largest independent study and about 2.8 times greater than the largest meta-analysis. And our results are in line with prior studies showing that an elevated D-dimer above 500 nanograms per milliliter could be useful because of its high sensitivity in making you go down a farther route to order CT angiography to confirm your diagnosis or obtain a TEE. If you, of course, had a D-dimer below this cutoff level, that could be very useful in excluding the diagnosis as it is very sensitive. So in conclusion, this large retrospective cohort study demonstrates that D-dimer is highly sensitive in assaying for acute aortic dissection. A D-dimer below 500 nanograms per milliliter could be effectively used to rule out aortic dissection in a low-risk patient. I'm here are the other authors, and thank you guys for listening to my presentation.